Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings on Fridays at 12 p.m. But during the summer, we'll be having briefings every other Friday, and I'll remind you of that at the end of this session. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. I'm joined this afternoon by two guests. First, Dr. Brian Garibaldi is director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give an update about treatment of COVID patients. Then, Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give us an update about COVID-19 vaccines. I'm now going to turn to each of our experts for a brief overview. Brian, gosh, what a difference a year makes when we think about this summer compared to last summer. So when you look back, what do you see as the key clinical lessons learned, and how, if at all, should we be applying them today?
The first thing I know Bill's going to touch on is that vaccines work, right? We're at the lowest rate of infections in well over a year. Hospitalizations are down, deaths are down. Many hospitals have had the opportunity for the first time in over a year to close dedicated units. And the reason for that is the vaccine rollout. So I think we need to continue to do our best to understand why certain people are still not getting vaccinated, to combat misinformation where it exists, to address people's safety, to make sure that people have equitable access to the vaccine. And that's going to continue well on into the summer. To make sure that we're trying to get as broad coverage as we possibly can. The second thing I learned is that other mitigation strategies also work. I think there's now a pretty overwhelming amount of evidence, laboratory experiments, as well as real-world epidemiologic data that masks effectively prevent the spread of COVID-19 and also effectively prevent the spread of other respiratory viral illnesses. This has been just flu since we've really been keeping track of the flu. The number of people hospitalized with flu has been exceedingly low, and the number of deaths from flu has been orders of magnitude lower than what we've seen with COVID. And I just remind everyone, we were worried about a twin-demic back in the winter when people were really worried what would happen when we got hit with the flu at a time when we were having COVID surges. So masks, we need to continue to have discussions, implement them effectively, and even think about if there are times where we would consider wearing masks during viral outbreaks to protect the vulnerable and to protect ourselves. I think we've also learned is early on, we got out of the gate a little delayed in terms of being able to test widely, and I think that we now know testing is really critical to understanding where the virus is spreading and to basically be able to move resources, to move testing, to move therapeutics, to move access to areas where the virus might be spreading. I think that's going to be critical moving into the fall, as we're going to have pockets of outbreaks potentially in areas that have low vaccination. Testing is critical. Now we need to start thinking about moving forward, how can we set up testing for other respiratory viruses, other pathogens that might be coming down the pipe. I think we've learned that health departments are critical to these local responses, but we've under-resourced for years. And so I think we need to really make sure that we're investing in that health infrastructure. And that includes a focus on the IT infrastructure that's been so critical to allow resources like the Hopkins Coronavirus Resource Center to be able to actually pull together data that actually moves policy and can help convince how to respond to the epidemic. And I think that also involves thinking about having a national preparedness plan. We were really fortunate at Hopkins to have a biocontainment unit that was able to help with the initial preparedness, actually take care of the first 3 to 4 weeks of patients to allow the rest of the health system to expand. And I think we're part of a regional and national network of biocontainment. We need to think and expand that moving forward to respond to the next thing. I think in terms of therapeutics, we need to continue to do active research on therapeutics for novel respiratory viruses, and in particularly for COVID right now. We're a year into this, or more than a year into this, and it means that remdesivir can reduce time to clinical improvement. We know that monoclonal antibodies can prevent people from being hospitalized, but we still don't have easy access to medicines that can be given in the outpatient arena. So there are some promising oral therapies and some other delivering some of these antivirals, but we need to continue to develop them and make sure that we can mobilize and have access to them for the next outbreak, but also for the continuing pockets of COVID that we're seeing. And then I think finally we need to take a step back and recognize COVID has really brought to light some of the inequities in our healthcare system and society in general. I think we need to move beyond just thinking about how COVID impacted those from those communities that don't necessarily have access to the same healthcare and have borne a disproportionate burden of disease. I think we need to look deeply at our healthcare system and see how we can begin to inequities, because we know that they have an impact on COVID, but they likely have an impact on diseases and other health issues. And I think we need to learn that lesson and continue to work on that as we move hopefully beyond thinking just about COVID in that regard.
Thanks so much, Brian. Before I turn to Bill, I want to remind our audience to please submit questions for our experts in the box at the bottom of your screen. Bill, vaccine uptake in the US seems to have slowed, and we're also hearing about areas of the world, including parts of Africa, that are experiencing truly distressing surges of COVID cases and deaths. So given these developments, both at home and abroad, what do you see as the current priorities for COVID vaccines?
Yes, thanks, Lainie. There are a lot of really important issues out there, and I just want to highlight what Brian was referring to. I think we're so fortunate here in the United States that we have access to 3 highly effective and safe vaccines that can prevent hospitalizations and deaths. But we still have a way to go to get ourselves out of this pandemic. And so there remain a number of priorities, both domestically here in the United States and globally. And I'll come back and end up talking about the surges, particularly in sub-Saharan Africa. But here in the United States, more than 310 million doses have been administered. 151 million Americans have been fully vaccinated. But when we look at the percentages, we can look at this as kind of a glass half full and a glass half empty. 45.6% of all Americans have been vaccinated, which means more than half of all Americans remain to be vaccinated. If we just look at those over 12 years of age, it's 53.3% who are fully vaccinated. So again, a large proportion of the U.S. population that's really eligible for vaccination still needs to be vaccinated. What I'm really struck by is the fact that now more than 3/4, 77.4% of adults older than 65 years of age are fully vaccinated, and 87.5% have received at least 1 dose. This is where we need to be for the entire population. It's great that those who are vulnerable, those over 65 years of age, have reached this kind of high rate of vaccination coverage, but we need to get those younger individuals vaccinated. The rate of vaccination here in the United States has declined from 3 million per day in early April to 750,000 doses a day. So we're now, averaging 7-day averages below 1 million per day. And as Brian said, this is a combination of some remaining challenges to access, but big challenges in demand. And some people are fearful or have concerns about potential adverse events, and I'll come back to that, but also a lot of information that's just dissuading folks. We're seeing, disparities across the United States, both racial disparities as well as geographic disparities, and where populations are under-vaccinated or unvaccinated is where we're seeing current outbreaks. President Biden, as we've talked before in these sessions, has set a goal of 70%, at least one dose by July 4th. Not clear we're going to reach that goal. 65.7% of adults older 18 years of age are currently have received one dose. And the Biden administration recognizes, and the data are showing us, that a lot of this is reluctance among younger people here in the United States to be vaccinated. And so I've been reflecting, as you know, on, what does it say about vaccine hesitancy when things like lotteries or beer giveaways influence people's vaccination decision to be vaccinated. And we're seeing more efforts really targeted toward younger people using TikTok videos or video game live streams or giving away concert tickets to try to get those who are young and perhaps perceive themselves to be at lower risk of COVID-19 to get vaccinated. And so I think these kinds of incentives, maybe they do tip the scale for a fair number of people who particularly don't see themselves at risk, and it becomes a motivation to get vaccinated. I wish they were really driven by the desire to protect themselves and those around them. Now, some big events this past week, Lainie. The Advisory Committee on Immunization Practices met on Wednesday to discuss the myocarditis and pericarditis in among adolescents and young adults in the United States, as well as booster doses. And more data were presented by the CDC on the myocarditis, which is inflammation of the cardiac muscle or heart muscle, and pericarditis, inflammation of the tissue surrounding the heart. More than 1,200 cases, actually 1,226 cases of myocarditis and pericarditis have been reported through the Vaccine Adverse Events Reporting System to the CDC. This is a passive reporting system, so anyone can kind of call in. 267 cases after the first dose and 827 cases after a second dose. Now, this doesn't mean that all of these cases are really caused by the vaccine, but obviously this is a very important safety signal that the CDC and FDA are taking very seriously, and they came to the conclusion, along with the Advisory Committee on Immunization Practices, that this inflammation of the heart or tissue surrounding the heart are likely associated with the vaccine. A very interesting, demographic. Largely young men and boys. Maybe about 80% occur in males. They're presenting with chest pain, fatigue. Some have disturbances in their heart rhythm. Many are getting hospitalized, but overall, it tends to be a mild course, and they recover. As I mentioned, the risk seems to be much higher after that second dose. And it's very interesting to me, Lainie, in terms of the pathogenesis, which we don't quite understand yet, but these are occurring really within a week, within several days of that, particularly that second dose. I do want to highlight that myocarditis and pericarditis do occur after or along with COVID-19. Maybe about 2 to 3% of young adults who get COVID-19 have inflammation of the heart, and particularly we see this in children who develop the multi-system inflammatory syndrome that can be associated with this. So this is a risk, a much greater risk among those who get COVID-19, and the general conclusion is that the benefits of vaccination still far outweigh the risk in this group. We expect that the Food and Drug Administration will now add a warning to the vaccine's packaging, and people are now aware, clinicians are now aware to look for this, and there's some discussion about potentially deferring a second dose if an individual, particularly a young man or adolescent male, develops myocarditis or pericarditis after the first dose. And I should emphasize these are being seen with the two mRNA vaccines, the Pfizer and Moderna vaccines. The Advisory Committee on Immunization Practices also discussed booster doses this past Wednesday. They presented evidence that antibodies persist for up to 8 months after COVID infection, and after up to 6 months after a second dose. We still need longer follow-up to see. There's no evidence right now that the general population needs to get booster doses. We do see some breakthrough infections, but these are expected. Breakthrough infections are individuals who get infected with SARS coronavirus 2 after 2 weeks after receiving 2 doses of an mRNA vaccine, or 2 weeks after a Johnson & Johnson vaccine. But there is consideration of booster doses in special populations, particularly the elderly residents of long-term care facilities and immunocompromised people. And I know Brian has talked before about the study that was done here at Johns Hopkins Hospital, looking at a third dose in patients who had received solid organ transplant, and seeing in about a third to a half of individuals getting a good antibody response after that. So we may see in the coming months recommendations for booster doses in some subpopulations, but I don't expect we'll see that for the general population. There is also, the past couple of weeks, a lot of news on new vaccines, particularly the Novavax vaccine, which is a protein-based vaccine. Really strong efficacy data, 90%, just really below that 94-95% that we saw in the phase 3 trials with the Pfizer and Moderna vaccine. So this puts it up in that top tier class of vaccine efficacy, really high efficacy in high-risk adults, and in a number of against a number of the variants of interest and of concern. So I know there's a lot of discussion, and I've been asked, is there really a role for more vaccines here in the United States? We've got 3 good, safe, and effective vaccines. I think there is, particularly for a vaccine like the Novavax vaccine. Protein-based, much kind of older platform for vaccine delivery. I've heard from some of my colleagues taking care of patients that they have some patients who would feel more comfortable with a Novavax type vaccine because that type of vaccine has been around longer than perhaps the newer mRNA vaccines. And there may be a role for a vaccine like this for booster doses. So I'm of the group that feels that the FDA should be providing emergency use authorizations for more vaccines in the United States. I can see a role for a Novavax vaccine, potentially even in younger individuals who might have some concerns about the myocarditis and pericarditis associated with the mRNA vaccines. I'll just end up, Lainie, talking about the global situation. You referred to that. As you know, I've lived and worked in Africa, in various countries in Africa over the past 3 decades, have many friends and colleagues there, and I'm very concerned about this large third wave that are many countries, almost a dozen countries on the continent are seeing now, particularly in Southern Africa and Eastern Africa. This is really concerning. I talked to one of my colleagues in Northern Zambia just on Tuesday. He told me about the hospitals being overfilled, oxygen in short supply. And what's really a tragedy is the shortage of vaccines that are available to people living in sub-Saharan Africa who are now facing this terrible third wave of cases. Only about 1% of the entire population in sub-Saharan Africa has been vaccinated. Out of the 2.7 estimated billion doses of vaccines that have been administered worldwide, only about less than 2% have gone to people in Africa. So this is really, a big global challenge for us to avert the tragedy. It's playing out like it played out in India, unfortunately, now in much of sub-Saharan Africa, and we're seeing surges of cases in South America as well. It's not solely limited to the African continent. We've talked before how the leaders of the G7 and the United States have pledged doses, but I think I think they're still way too short. The more needs to be done. The G7 pledged 870 million in the U.S., 500 million doses, but that's over, part of this year, part of next year. Many more doses need to get out there. As we've talked before, the World Health Organization estimates a need for about 11 billion doses to get 70% of the global population vaccinated. COVAX had pledged 2 billion doses by the end of this year, but they're far behind, have only distributed about 90 million doses. And so I'll just end, Lainie, with something I've talked about before on these sessions, briefings. The 4Ds for successful vaccine delivery or successful vaccine rollout: doses, delivery, demand, and data. Right now, we have a severe bottleneck and shortage of doses. Manufacturing needs to be scaled up, but we also need to be supporting other countries in getting those doses out to the populations that need them, increasing the demand by combating misinformation, and helping them collect the data so that they can monitor their progress. And I'll stop there, Lainie.
Thanks so much, Bill. I'm now going to turn to questions that have been coming in from our audience. And Bill, no surprise, a lot of questions about the Delta variant today. So first question for you, can you talk us through the differences or maybe similarities between the Delta variant and what folks call the Delta Plus variant?
Yes. Yeah, so we're just learning about this new variant. It was first identified in England, where they're doing a lot of sequencing, and the fact that it's being identified there, I think, is a reflection of how much sequencing they're doing. So this Delta Plus variant has one additional mutation in the spike protein gene that was also a mutation. It's been seen in some other variants, but particularly in the beta variant that was identified first in South Africa. And why it's generating such concern is that it may confer some ability of the virus to escape immune protection. And that's why it's generating a lot of discussion. It's been identified, my understanding, in at least about almost a dozen countries right now. It's certainly been identified in the United States. It's not a widespread variant, but it's raising concerns because of this potential, at least, for those variants to evade some protective immunity, either from prior wild-type infection or from vaccination. Now, I will say we don't know that for sure yet. It's going to be intensively studied, so we have a lot more to learn about it. But again, in short, to summarize, it has an additional mutation that was seen in the beta variant that could potentially help the virus escape immune protection. Thanks,
Bill. And to follow up on the remarks that you just made, do we know anything about the specific COVID vaccines and how they hold up to the Delta variant? So meaning differences among Moderna, Pfizer, J&J, et cetera.
Yes, I mean, we'll certainly still learning. And, obviously the Delta variant has increased dramatically in the United States as a proportion of all the infections, up now over 20%, and it's increasing rapidly. The bottom line is that right now, all three vaccines, the Pfizer, Moderna, and the Johnson & Johnson, appear to be highly protective against severe disease, which is our main concern, against the various variants of concern, including the Delta variant. We don't yet know about this Delta Plus variant. There just hasn't been enough information yet. But I think the bottom line is that we can still be confident that our current portfolio of vaccines here in the United States are going to protect us against the Delta variant. We haven't yet seen the breakthrough infections. But this just emphasizes, Lainie, how important it is, as you well know, that everyone gets vaccinated. Everyone who's eligible gets vaccinated, because we're already seeing, outbreaks in undervaccinated populations here in the United States, and that's just going to continue.
Thanks, Bill. Couldn't agree more. Brian, question for you about risks of severe COVID disease among those who have diabetes and have been vaccinated. So first, what do we know generally about that? And then second, does your answer change when you consider the variants in the population now?
Yeah, so important questions. We know that pre-existing conditions, particularly things like diabetes, heart disease, lung disease, predispose you to worse outcomes if you do get infected with COVID. But we also know that the vaccines, by and large, provide protection across those populations. The people that we're most worried about getting sick after a vaccine are people who have something that prevents their immune system from making a robust response. And that usually includes patients who are on immunosuppressive medications, particularly patients who have had solid organ transplants, bone marrow transplants, or on medications for underlying immune system conditions. Patients are at risk for not mounting an antibody response, and that could translate to a higher risk of them getting infected. Vaccines are not perfect, right? So they're highly, highly effective, but people can still get symptomatic COVID after a vaccine, but we have not seen a clear signal that people are getting hospitalized or having severe disease or death in specific subgroups that have mounted an immune response to the vaccine. What I've been telling my patients on immunosuppression is to be very careful. We have been checking antibody levels. We're not quite sure how they correlate to whether or not they're truly protected. There are some emerging case reports of people on immunosuppression getting a third dose of a vaccine. Maybe they got 2 doses of Pfizer or Moderna, and then they're switching and getting another dose of another one. And in those case reports, it looks like those patients have a higher likelihood of developing, but we don't understand if that's the right strategy yet. So I've been telling people who have concerns, who have underlying health conditions, to get vaccinated, number one, but also, to think about their own personal circumstances and think about their level of risk. But don't consider someone who has diabetes who's been vaccinated at higher risk than, say, someone who doesn't have it who's been vaccinated. The important thing is that they get vaccinated.
Thanks, Brian. Bill, question for you. In your opening remarks, you spoke a bit about the Novavax vaccine. Do you know anything about the timeline for when it's likely to be available in the US or potentially elsewhere?
Yeah, so we don't know for certain, but I'm expecting in the next maybe 2 months. The issue is going to be whether, or one issue is whether the FDA will be willing to issue an emergency use authorization, or whether they will ask Novavax to just apply for full approval. Should it be the latter, that will take much longer. That's at least several months at least for that. I'm hopeful that they will recognize, that the FDA will recognize that there is a need for an additional vaccine under an emergency use authorization here in the United States. And these EUAs are only administered or authorized when there's a public health emergency. And I think, I expect that we're going to still have a public health emergency here in the United States in the coming months, given, the potential for these new variants and potential for surges in infection in the fall and the winter. I hope we don't see that. I hope we continue to see declining transmission and declining cases and hospitalizations and deaths. So I maybe I don't have exact, but maybe a month or two, maybe a couple months for that EUA. Yeah.
Thanks, Bill. Brian, question for you. What do we know about vitamin D3 levels and COVID?
So there's been interest years in looking at the association between vitamin D levels and respiratory illnesses, looking at vitamin D levels and critical illness in the hospital. And so that same interest was applied to COVID. And there were early on stuff like perhaps there was an association between people who had vitamin D deficiency and the risk of developing severe COVID. By and large, that has borne out to probably not be true. I mean, vitamin D deficiencies is very prevalent, and associations were probably not causal. There have been a few trials looking at large doses of vitamin D3 administered to patients either as outpatients or if they get admitted to the hospital. Part of the data has not shown a clear benefit to giving people doses of vitamins, either an outpatient medicine for COVID or to try to treat people in the hospital. So the principles seem to potentially be worth investigating, but so far they have not panned out to be successful either in COVID or in other respiratory diseases or even in sepsis.
Thanks so much, Brian. And we're closing in on 12:30, so I'm going to wrap up. I'd like to thank Brian Garibaldi and Bill Moss for joining me today and give a big thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available at coronavirus.jhu.edu. As a reminder, we will offer these 30-minute briefings on Fridays at 12 p.m. During the summer, we're going to offer them every other Friday. So that means that our next briefing will be Friday, July 9th at 12 p.m. As always, in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing. And until then, thanks and stay safe.